So as discussed, CPAC classification is now the talking point in all alignment circles. But how relevant is the classification to Indian patients and surgeons in India? And where do our patients fit in? Are there any limitations to this classification that we need to consider when we are implementing it? So what's the ideal approach? When we adopted robotics 4 years ago, we first wanted to understand how to use the technology at hand, because technology by itself is not the solution. It's the surgeon preference and the choices that the surgeon makes which has all the impact. So we looked at an internal review of the 5,000 cases that were performed at our institute over 2 years, and looking at this classification system from theme point, you can see that our knees are very different from the Western knees, and we have a huge proportion of patients, almost 60%, which have substantial to extreme deformities. So personalized alignment was always low on our priority list. We always assumed that alternate alignment strategies are not ideal for our patients. And this is where we delved into the CPAC classification, and we wanted to evaluate how the phenotypes are in the Indian patients. So this was a prospective cross-sectional study that we did, and we made sure that we were evaluating both the non-arthritic young healthy adults versus those patients who are also opting for a total knee replacement because of osteoarthritis. So we looked at 1,000 knees in total. So you can see that the majority of the arthritic knees were in varus alignment and apex distal as discussed, type 1. But there was something which was more important. As you can see in this slide, in the young arthritic knees, as it was shown in the Western literature as well, the proportion of patients with type 1 or type 2 is actually pretty much the same. So there are a significant number of type 2 knees in the younger patients. And as the arthritis progressed and we're looking at the arthritic patients, there's a huge shift from this type 2 to type 1. So does that really mean that we are all that different from the Western world, and are we all CPAC type 1? Or does it talk about which CPAC type is more likely to progress into arthritis? And as we showed, this was compared with the literature where we had a much higher rate of type 1 in our arthritic patients, whereas type 2 was lower, and this was a similar finding in the Asian population. Now we finally come to the relevance of choosing alignment strategies, especially in the Indian patients. So we wanted to look at restricted kinematic and functional alignment mainly because unrestricted kinematic alignment is a little extreme. So as we said, we wanted to match the native alignment with restricted boundaries in restricted kinematic, whereas functional alignment gives you the opportunity to adjust both the femoral and tibial components for balance. But which alignment is more suitable for this type 1 knee that we face in our regular practice? So we first wanted to evaluate the feasibility of these alternate alignments, to compare what proportion of knees could be balanced with each one, to define these laxity patterns that we get at the end of the procedure, and to understand the shift in the knee phenotypes that occur with either of these things. So we did an observational study with Mako robotic assisted in patients, and this was essentially a simulation study done on the same knee. In all these patients, we put the surgical plan according to all these categories. So we put a pure kinematic plan, we balanced the knee to see if it was balanced or not. We further changed it to restricted kinematic and then functional alignment. So balance obviously defined based on the quantitative balance that we get from the robotic data with a difference of less than 2 millimeters in the mediolateral compartments. So as you can see in this slide, we achieved balance significantly higher with functional alignment, which was almost up to 60% of our knees could be balanced with functional alignment, whereas restricted kinematic alignment actually balanced only around 30% of our knees, because there was some amount of residual lateral laxity or persistent medial tightness with this strategy. And up to 13% of our patients could not be balanced even when we maxed out functional alignment, which is a very important point that we need to note. As far as the joint line obliquity is concerned and the CPAC phenotype, restricted kinematic, though it was associated with a little bit of imbalance, it was maintaining the phenotype in all these patients. Whereas functional alignment gave you excellent quantitative balance, but then we moved away from CPAC. So then we wanted to understand what clinical implications does this have, because these are all just radiological parameters that we are throwing around. So you can see here that the percentage of changes, proportion of patients who were changing phenotype was significantly higher in functional alignment, almost 95% of them. So what are the patterns of imbalance that we notice? So obviously, most of our Indian varus knees have a combination of excessive lateral laxity and medial tightness. So when we applied this restricted kinematic strategy, we either had residual lateral laxity or a persistent medial tightness. And we had to do a posteromedial release or a semimembranous release at the tibia and posterior capsular release on the femur. Now, how much of release would be done would obviously depend on the surgeon's tolerance and his preference about what lateral laxity he is ready to accept in these patients. So we published recently about a comparison of functional alignment versus mechanical alignment in the Journal of Robotic Surgery, looking at the early outcomes in terms of pain difference, the number of soft tissue releases which were required. And you can see that for the same deformity, we were having to do the number of releases almost twice in number as compared to functional alignment. When we looked at the postoperative clinical data, there was an early benefit in terms of reduction in pain with functional alignment. However, this effect was pretty short-lived, and probably by around 6 months, there was not much of a difference when it came to the functional outcomes. So we are in the active process of looking at the 2-year outcomes to see if there is any sustained benefit of functional over mechanical alignment. Then we wanted to compare functional with restricted kinematic and see, are we looking at anything different? So this is an ongoing study where we wanted to actually compare the perception of the joint for the patient, which is obviously using the forgotten joint score and other prompts, look at the soft tissue releases, thickness of the bone cuts, change in the phenotype as we did in the previous studies. So you can see again with the pre-balance, functional alignment was, again, compared to restricted, it was significantly better balanced. The soft tissue releases were significantly lower with functional alignment, and we invariably had to do something about the extension gap. Flexion gap was easy to balance because of the versatility in the rotation of the femoral component that we were able to give. The CPAC phenotype change, we actually started seeing some shift both in functional and restricted kinematic, but you can see that the shift is much larger and we are causing a very neutral joint line with functional alignment. So in inference, the functional alignment was associated with a better quantitative balance, reduced soft tissue releases compared to RK, but the prompts were again comparable at short term, probably around 6 months and even at a year. Longer term follow-up with added outcomes, especially about the joint perception as far as the forgotten joint score. And are we really finding a difference in the different aspects of the patient's knee function? As we can see with objective scores such as the Knee Society score, we are yet to see any concrete difference. Some of the emerging evidence has shown a lot of difference in the forgotten joint score. So we are hoping to see if our data can either prove or disprove the same, and we are open to having the discussion. So the take-home message would be, we still recommend mediolateral gap balancing to be the absolute standard for all surgeons, irrespective of which technique you use. Be careful, even with assistive technology, in choosing the right alignment strategy for your patients. So although there is some emerging evidence of prompts comparison in favor of alternative alignments at this point, it's always preferable for young surgeons to choose one successful strategy and then stick to it in the vast majority of your cases to have reliable and sustained outcomes. Thank you.